So, dear friends, good morning. Again, thank you for a lovely session yesterday. We had a nice mixture of research, science, friendship. And as you can see on the picture below, Dr. Golano was not cold at all yesterday night. Now, we will discuss the osteochondral defect of the talus. Where do we stand today? If you want to know how to prevent and treat OCD lesions in the ankle or lesions in the ankle, the first thing to do is to understand the joint itself. Now, what makes the ankle so special? The ankle is a highly congruent joint. It has a thin cartilage layer. There is a tibio-talar contact of an average of 4.4 square centimeter. And we know that when we consider the ankle joint forces, there is a decreased local stress on articular cartilage, and the forces spread over a wide joint area that is not a concentrated area. When we compare that to the knee, for example, a less congruent joint, we see in the knee there are compressive loads with a narrow area. There is a thicker articular cartilage layer, and there is an increased joint stress. But the thicker cartilage layer deforms, and this increases effectively the load-bearing area in the knee and decreases the local joint stress that are upon it. Cadaveric studies show that the thickest cartilage in the ankle is seen in the medial corner, the thinnest in the lateral gutter, in both men and women. Now, when we look at the distribution of the cartilage thickness, we see that on the anterolateral part of the ankle and the posteromedial part, so in the red area, there is the thickest cartilage. And that has a repercussion because these are the two areas where we frequently see the lesions. Now, there is a big difference between a lateral lesion and a medial lesion. Now, the lateral lesions, they tend to do better than the medial ones. They are more frequently associated with acute trauma and instability of the ligamentous tissue. Since it's a more acute lesion, we tend to treat them with an open reduction internal fixation with good success. But sometimes we need to treat the fragment itself with abrasion or microfracture treatments. This is a case of a 19-year-old volleyball lady with a post-traumatic injury of the ankle. You see here the acute lateral lesion in the tibio-talar joint, and mainly it's on the anterior part, but particularly here, it was more posteriorly located. This is A, this is P, and this is lateral and medial. So you can see here it's somewhere more towards the posterior side. So it makes it a little harder because the good thing is if you have an acute trauma with an OD lesion fracture in the ankle and it's mainly anterior laterally localized, you can fix it easily with a little mini open incision. But if it's there, you have to make an oblique osteotomy, fix the fracture, and then you see how we can stabilize it. Now, these are results 5 months post-op, and you can nicely see with the lateral lesions that we can really address the joint line. There is no step off, there is no diastasis, although you can see there is a little stress shielding with a little cystic deformation in the end, but still we have a good coverage of the articular cartilage layer. Now, what about the medial lesions? They tend to be more chronic, more larger in size, and they do worse in outcome compared to the lateral lesions. For this reason, we have other type of techniques with drilling, rarely an internal fixation, and mainly the excision, debridement, and bone marrow stimulation techniques that I will run over with you now. Now, these are the two items, the medial and the lateral lesions, but still up to today, we have problems in treating the bigger cartilage layer problems in medial and lateral lesions. Now, what we recently do know is that it's not because you have an ankle instability or you have a traumatic incident or you have a chronic ankle lesion in a young or aged athlete that it can predict the location of the ankle lesion. That's what we know now. But the biggest question of all, the real question in OCD, in osteochondral defect of the ankle is, why is it painful? Is it because there is a superficial cartilage layer problem? Is it because there is an osteochondral defect on the layer itself or in the gutter itself that comes prominent and gives the pain? Or is it because the subchondral area has become sick and it gives depressions of the layer onto the subchondral area? So perhaps my video will work now. So this is a medial part of the tibio-talar joint. And you can see that there is a medial lesion. I go with the probe inside the lesion. And the biggest question is it because of the impingement of the fraying of that lesion onto the joint itself that it's painful? Or is it really a problem from within? For that answer, we have to go back to science itself. Now, the loads applied in the joint, they push the intra-articular fluid into the subchondral area, and they create pain and cystic changes into this subchondral bone, and this is where the nociceptors are. So we tend to believe that it's not really the damage itself, but it's the load that pushes the fluid inside that gives the pain and the cystic changes. So do alignment and instability change the loads upon the cartilage? If you know that in a normal walking, there is a load of average 550 Newton per square centimeter onto the joint itself, and if you consider that there is due to a lateral talar shift, a 1 millimeter shift, it decreases the loss of contact area with 40%. So this means that with 1 millimeter shift, the loads almost double on the ankle joint. If you consider 2 millimeter shift, the loads almost triple. So that's quite astonishing. What about ankle joint loading? We know that malunion of a fracture resulting in that shift of 2 millimeter, as I just showed you, almost triples the ankle load per square centimeter. And we know that a debridement of a 9 millimeter lesion, an OD lesion, increases the load on the remaining articular cartilage into that joint. And probably that lesion is not large enough to damage the remaining cartilage unless there is malalignment, mainly in varus. So this is a picture that shows it all. It's a friend of mine who sent it. It's Gino Kerkhoff. Now, this was in a colleague of theirs, an orthopedic surgeon in the Amsterdam hospital of 50 years old. And he suffered from a fracture, a very stable fracture, but they discussed it and they said, we will go for a percutaneous distal fibular fixation to make sure that it heals well. Now, what did they see? The fracture was stabilized. But for which reason or another, 9 months later, you can see here, in comparison to the previous picture of the fracture itself and afterwards, that there is a cystic change into that lateral talar dome. Now, they didn't treat it in an arthroscopic way. They just changed the alignment. They made the sliding osteotomy of the calcaneus, put it in varus, and then they changed the loads upon it. And up to today, there is still no true lesion in the joint itself. And the cystic change, it stayed like that. So it remained in an equilibrium. So the alignment is the key factor in summary. And by addressing the loads to spread over a wider area in assessing the alignment, you respect biology. And consequently, biology will respect you. Now, what about instability? Does instability play a role in the formation of chondral lesions? There are studies, a study with 99 ankles in chondral injuries with chronic lateral ligament instability showed that patient age, talar tilt, and malalignment mainly in varus increased the risk of chondral changes. However, there is no evidence that instability in the presence of such lesions increases the risk of osteoarthritis into the joint as an evolutive measure. Now, we just finished a study in which we performed in every chronic lateral instability of the ankle that was planned for surgery for a Brostrom operation, which means a reconstruction or a repair of the ligament itself. We performed prior to that open surgery an arthroscopic procedure just to see the findings into the joint itself. The chronic instability was a mechanical and functional one, and it was a chronicity between 7 months and 4 years' time. Now, what we saw that considers this talk is that we saw 100% synovitis into the joint. We saw talar fibrillation in 25%, talar dome lesions in 14%, and Taylor OCD lesions in 7%. So it's still a question what that really tells us, but it strongly suggests the high amount of combined intra-articular pathology in patients with a chronic lateral instability of the ankle. And then let's quickly run over on some theory. Now, if we want to compare lesions, we first have to know how to describe them. And since 59, excuse me, Burns and Hardy made the first classification of the OCD lesions in the ankle. They made a standardized algorithm, and that was our starting point. Now, just to tell you how the classification works, their classification was a radiological one, and nowadays we have MRI that helps us a lot. And we've seen in the studies that MRI can be used to evaluate the articular cartilage covering osteochondral lesions with a high degree of accuracy, and thus may aid in identifying patients who would benefit from a definitive arthroscopic treatment. And then, of course, an MRI classification was there. Now, on the other hand, MRI is a really useful tool to address a classification with the MRI classification system. But another study shows that drilling did not always improve the MRI and the arthroscopic findings in a patient that was treated for a lesion. However, the clinical results were there and the scores were excellent. So this means that MRI is a good tool to address and describe the lesion, but might be a bad tool to address the follow-up, the outcome scores, because it doesn't give you an accurate description of the evolution of the lesion. I think it might be an idea to talk with the radiologists on this, because there's still some pioneers work to do in this way, I think. Now, I won't run over all the classifications because we have the expert of experts on classification here in the room. Just to make a summary, that nowadays the ICRS cartilage classification is the one we use here. Now, if we talk about osteochondral defects, which of them progress? Is it a start of an evolution towards degenerative changes? Now, a study that did a 10-year follow-up in 45 Taylor OCDs with bone marrow stimulation, 62% were excellent scores, 18 were reoperated, and 16 progressed towards degenerative changes into the joint. We know that obesity, an age above 40 years old, and preoperative degenerative changes are, of course, the main predecessors of such an evolution. But another study showed that it's just a follow-up study with MRI, patients with OCD lesions that were not treated surgically. And in 9 patients of the 29, there was no change in evolution after more than 1 year. In 7, it improved. In 13, it progressed towards degeneration. So in conclusion, we see that some cysts and some bone marrow edema on the MRI, they resolve. But there is no reliable sign of correlation between the lesion severity and the progression towards osteoarthritis. Now, in conclusion, it's not that early osteoarthritic findings in the ankle can extrapolate specific findings in tibio-talar angles or hindfoot alignment. Another question that rises is there a critical defect size for poor outcome in our scores afterwards? Now, what we use is the recommended treatment since '94, in which states that the arthroscopic defect size cannot be over 150 millimeters square, because then we tend to use the mosaicplasty or newer ACI techniques. The arthroscopy has excellent results, which I will show you, when you consider a lesion below that 150 millimeters square. So that's our cutoff. But significant changes in joint contact characteristics for large chondral defects are there, and it's stated in the article that it's above 350 millimeters square, but we tend to believe it's less, starting from 200, 250 millimeters square. So for big lesions, as you can see here, microfracture is an option, although more and more we tend to advise not to use the technique, because we really don't know what the effect will be on the joint surroundings. We start to know it, but we are convinced that we have to fill up this gap in any way just to make sure that the evolution towards the normal articular cartilage surroundings is not there. Now, recent literature supports these findings, especially for arthroscopically treated lesions below 150 millimeters square, showing that it's a safe and effective procedure to treat the lower lesions below 150 millimeters square with arthroscopic, in an arthroscopic fashion with microfracture and bone marrow stimulation, providing good clinical outcomes in the majority of patients. A long-term result is also what we want to know. And the long-term results show that arthroscopic treatment of these chronic lesions result in good clinical outcomes. However, pain and limitation of function may persist in some patients, especially those that were noted to have an unstable OD defect at the time of arthroscopy. A case, it's not always a clear case. These are nice theories, but the surgical options really have to be fine-tuned with the lesion itself. And some of the next cases show this. This is a lesion, a bony lesion, in the medial talar dome lesion. But what about a bone lesion with a cystic change underneath? Every time we have to go back to clinics, go back to our imaging, and find out, with regard with what the literature tells us, how to treat these patients in a very individualized fashion. Here you have a very big defect in a young person. On the other hand, when you have ATFL instability, it can give deformities due to the shifts. So you always have another type of lesion. Another case shows that the articular cartilage tends to be good, but there is just a big cystic change underneath. Every time we have to go back and think, why is it painful and how do we treat it in the most proper way? Keeping in mind that we're treating sports people mainly, or people that want to have a recreative way of life. Now, of course, we tend to go more minimal invasive, and as I show you here, you treat the articular cartilage lesion, you put the probe into the lesion, and you drill underneath to fill up the gap of the cystic changes. That is an option. It's not always the best, it's not always the worst, but we believe that with minimal invasive techniques, we can get there nowadays. What we also know in these cystic changes is that transmalleolar drilling is not done anymore due to severe damage and kissing lesions. The retromalleolar drilling is still something that we use for specific cases. Now, we won't go too technical, but what we want to know is the systematic review. And there is a nice review on the techniques to treat these kind of lesions by Maartje Zemmerink in 2010. It shows that excision, curettage, and bone marrow stimulation to make it complete, let's say microfracture, has an 85% success if a lesion is below that 14 or 15 millimeter. And we use Oates technique, which I will show you, with good success in bigger lesions, although there is the harvesting problem with morbidity in the knee where it mainly comes from. Now, this review showed that we cannot draw definitive conclusions nowadays, and further studies are, of course, necessary to really know how to deal with every specific kind of lesion. What we do know, in conclusion, is that size does matter. The 14-15 millimeter cutoff is really what we aim for in our imaging techniques to see how we have to deal with them in a treatment option. Also, the site matters. Spontaneous medial is worse. Now, we know that we have to think only or mainly at the subchondral bone, and that alignment probably is not important initially, although varus malalignment is at stake. And instability probably needs addressing, although up to today we have no RCI evidence for that. Now, unfortunately, large OD lesions of the talar dome still pose a special problem to the young population, and success rates have been reported up to 78% through stabilization of biological measures and non-biological measures. I quickly run over with you. The non-biological measures are for the big lesions that we want to treat. Now, in a case like a competition dancer below 30 years old, with chronic pain in daily life, effusion that is persisting, had 2 previous arthroscopic debridements, no instability, and some giving way, we see, when we do an open technique, a big lesion of the medial talar dome. Now, Today, we have the options of treating them biologically or non-biologically, but there is now research coming up with good data and credible data to show that kind of metallic implant, the French call it a punaise, to plug in is a good option in these kind of lesions. We anchor within the bone for stability, and then we plug the implant on top of it. And the only thing you have to aim for is, of course, fill the defect, put it in good alignment, but mainly make it flush with the joint, of course. And the technique describes that you have to go a little deeper so there's no problem with step off into the joint. Then we close up, and these are the X-rays that we see. In plantar flexion and dorsiflexion, you have the gap completely filled. What about other type of lesions, the big lesions with more than 2 centimeter defects? How do we treat them? Because it's always a tailored kind of treatment. The other non-biological or pseudo-biological treatments are the synthetic plugs that we tend to use in order to have less morbidity with the Oates technique. Now, this is how we do it. We put the synthetic plugs into the defect, and we do some microfracture around, and we try to fill up the gap again. And this is how it looks like with the osteotomy. On X-ray, we see the evolution, and that's the problem, that sometimes with these kind of plugs, it takes more than 2 to 3 years before you have a radiological evaluation that gives you good appreciation of the tendency of healing. Now, there is a Budapest group by Laszlo Hangodi who has a lot of experience with the Oates technique. It means that you use your own plugs, coming from the knee mainly, to plug in and fill the defect itself, and he has nice results on that too. But now we consider really the big lesions. Now, when you do Oates like these, we see a tendency that the articular cartilage is remaining good, but there is a tendency of bone to come back as a lesion. So we're not there yet with this technique either. And for this reason, and because of the morbidity of the knee, that you make a knee painful sometimes in 12%, a knee that was not painful previously, to treat a lesion in the ankle, some authors try to find other ways to do a biological plug, to harvest that. And there is a paper showing that you can take it from the posteromedial part of the ankle. But I still have my doubts personally, perhaps it's a name for discussion, how it will resolve, because we really don't want to create other lesions to treat another one. Now, when nowadays considering the appropriate treatment for a large talar dome lesion, it's important to separate the short term from the long-term goals. And in the short term, the goal is to reduce pain and improve function. In the long term, the goal is to forestall the development of osteoarthritic changes into the ankle while maintaining pain relief. And just towards the conclusion, we know now that the new techniques are really looking promising, and we have data that is rising, and especially for the big-sized ankle lesions, we have really promising data, and we hope to learn more about it in a minute. But the new autologous chondrocyte implementations or implantation techniques are the ones that we nowadays follow very closely in literature, because because of the poor quality of previous harvesting patches, there are now membranes that give very little complications and that can improve the scaffold or the ingrowth of the new tissue. However, the results of this AC and MACI show that we're still a long way from regenerating articular cartilage in the ankle, and therefore new techniques are coming, like in these, a big ankle-sized lesion, and there are now techniques showing to use baby cartilage and fibrin glue to fill up the defect in a biological way. Now, to end, when 19 years old Sir Winston Churchill was asked what the secret of his good health was, his answer was, never sports. But if we dream about helping our athletes to perform at the highest level, I intend to keep in mind the words of the French author Marcel Proust, who said, "L'espérance est un acte de foi." It means hope is an act of belief. And if people like Professor Kennedy can keep up having good work and showing that with the new results and symposiums like this to join forces, if we can make sure that the hope is still there, I think we will get there, and we have the belief. Thank you.